All right, so in this video, we're going to talk about AV blocks. So far, we've covered sinus rhythm, atrial rhythms, junctional rhythms, ventricular rhythms. Now, this is our last group of rhythms because these rhythms are having problems with something in a conduction system, whether or not it's come from the SA node, there's a block at the AV node, or it's an issue within the ventricles. So we're going to briefly discuss an overview of AV blocks, what they are, then dive into each individual rhythm themselves. So what our plan is to discuss our All right, so in this episode, we're going to discuss AV blocks. So we're going to learn what AV blocks are, how to interpret AV blocks, and then what are some of the possible treatment options for the various AV blocks. So far we've learned about the conduction system of the heart, SA node, the AV node, the bundle of His, and the Purkinje system. So that helps us, as far as having a good grasp of that, helps us understand what happens with AV blocks and what is going on for each block. So what we're going to discuss is we're going to describe the ECG characteristics, the possible causes, looking at signs and symptoms, emergency treatment, and management for first degree block. We're going to do that for the second degree block type 1, same for the second degree block type 2, for secondary 2-to-1 conduction, and also we're going to look at the same for a third degree block. So first, let's quickly review what is the AV junction. So the AV junction is the connection between that receives a signal from the atria and sends that impulse down to the ventricles. So we're going to receive this. So the SA node sends out the signal, goes to the atria for depolarization. That impulse is, as it travels through the atria, through the internodal pathways, Bachman's bundle, that stimulus makes it to the AV node. And then from the AV node, it holds on to the signal and then sends that signal down to the ventricles. So it holds on briefly at the AV node to allow for atrial kick, so we can have good maximized filling of the ventricles. And then it goes down from the AV node, bundle of His, and then the bundle branches to the Purkinje system. So if we have a block here in the AV node, that's going to leave us with an AV block. So whether or not it's a first degree AV block, a second degree, or a third degree. So all that's happening here at the AV node. So the blocks are traditionally classified in two ways. One is according to their degree of the block and or to the site of the block. So, and one thing is the PR interval is a key differentiating type to deciding what type of AV block we have. So in other presentations, talking about the importance of the P wave, and absolutely is. So we have the P wave, we have the PRI, and then obviously the QRS. So under normal circumstances, at least for a sinus rhythm, you have a upright normal P wave, PRI less than 0.20 seconds with 1-to-1 conduction, one P wave for every QRS. So you have the P wave upright, PRI is within normal limits, and then one P wave for every QRS. So under normal circumstances. Now we're going to look at, do you have more P's than Q's? Do you have more P waves than QRSs? Do you have, what is your PRI? So all these are going to be deciding factors that we have to investigate in that ECG rhythm to determine what rhythm we have. So the key to differentiating the level or the location of the block is the width of the QRS complex. And in the second and third degree or a complete AV block, the rate of the escape rhythm. So we learned about escape rhythms looking at junctional and then ventricular rhythm. So a junctional escape is, we have a narrow complex, may or may not have a P wave, and if it is present, it's going to be inverted with a narrow complex that occurs after the next expected beat. So, escape beat's happening because its conduction impulse is faster than that of um, the originating pacemaker. So if our escape rhythm is beating at 50 times a minute, or it's what it wants to beat at, and then our sinus mechanism is only beating at or sending impulse at 40 times a minute, 30 times a minute, then that escape rhythm may become a pacer. So junctional rhythm, narrow complex, may or may not have a P wave, and if it is present, it's going to be inverted. Ventricular rhythms are going to be wide complexes, and if a P wave does occur, it's either going to occur during the complex or after depolarization of the ventricles or after the QRS complex, and that P wave will be inverted. Why? Again, because we're going from a positive electrode, our left leg, to our negative electrode being our right arm, so it's traveling in a retrograde format. So we're going to look at these blocks. So a first degree AV block is a type of incomplete block. Same thing with a type 1 and a type 2 of a second degree. Both of these are incomplete. And then we have a third degree AV block, means complete. So what does an incomplete versus complete block means? So an incomplete block means it's that electrical impulse or stimulus is blocked sometimes. It's not an absolute. It may vary, but there is some connection between the atria and the ventricles through the AV node. It may not be functioning properly, but there is some communication and some connection. With a third degree AV block, there is no communication. So basically with a third degree block, your atria are doing its own thing and the ventricles are doing its own thing, and there's no communication there. So incompletes are first and second degree blocks, and then your third degree is your complete block. So our AV node is a first degree AV block, second degree AV block, or a third degree AV block. And this is where we're looking at the AV node itself. If we have a blocked AV node, it's going to be either first degree, a second degree, or a third degree block. And as far as any infranodal or subnodal blocks, if we have a block at the bundle of His, can lead to a second degree AV block type 2 or a third degree AV block. And then if we have a block in the bundle branches, maybe a third degree AV block or second degree AV block type 2. So it's more common here. Ultimately, don't necessarily expect you to memorize this, or our whole purpose is interpretation of the rhythm. So having a little background information about whether or not it's happening in the AV node, the bundle of His, or in the bundle branches can help us narrow down some of the classifications of it, but it doesn't necessarily, it's not necessarily required for interpretation. So looking at this image here, our AV node, this is where the first degree, second degree, type 1, and a complete AV block is going to occur in the AV node. Bundle of His is a second degree type 2, and then a third degree or a complete AV block. And then in the bundle branches, maybe a second degree type 2 or complete or a third degree block. So the significance of these AV blocks, we're looking at clinical significance here. So, and it's not just all about treating your monitor. It's not about treating your monitor. It's about treating your patient. So now we utilize the information we obtain from the cardiac monitor and to help come up with a differential diagnosis and to help come up with a treatment plan. But just because we see a certain rhythm on the cardiac monitor doesn't mean we absolutely have to treat it. We really need to look back and see what's going on with the patient. Is our patient symptomatic? Are they exhibiting signs and symptoms of it? Are they stable or they're unstable? Now, so the clinical significance of the AV block depends on what? Degree or severity of the block. So obviously a first degree is not as bad as a third degree. A rate of escape pacemaker, so this is the escape rhythm, whether or not it's a junctional versus ventricular escape beat or escape rhythm, because that can help determine what treatment regimens we may follow. and then a patient's response to that ventricular rate. So even if somebody's in third degree block, is it a junctional escape? Is it narrow complex or is it wide complex like we would see in the ventricular escape? And then how are they tolerating it? How is perfusion? How's their blood pressure? How's their mental status? So all these are going to play a role in significance. So, so that's a brief overview of the AV blocks. What we learned is that depending on the location of the AV or the block, or depending on the location of where the block is occurring, depends on whether or not we're looking at a top 1, a secondary top 1, a secondary top 2, a first degree AV block, a third degree AV block, or also known as a complete AV blocker. Also, we've looked at some of the fundamental characteristics of AV block and what are needed. So under normal circumstances, 1 P wave for every QRS, and that PRI is within normal limits. With AV blocks, we're going to start seeing those changes. Either you may have more P waves than you do QRS complexes, you have a prolonged PRI, or you may have a varying PRI. So all those 3 components there are going to be instrumental in us determining and identifying AV blocks.